talk about the posterior circulation first, and then the last couple of slides will have to do with the carotid collar, the carotid rings, this clinoidal segment of the ICA, and all the controversy that ensues over those various terms. So this is a distilled version of the very complicated embryology that the vertebral artery is going to go through. So about the end of the first month, the dorsal aorta has given off segmental branches, and those segmental branches, through a complicated progression, will regress and eventually lead to the adult vertebral artery. Paget, if you're all vascularly oriented and you haven't read her sentinel papers on the development of the intracranial fetal arteries, I suggest you grab that, read it. It's very dense reading, but it's well worth the time. These pictures are renditions taken from her text, and essentially on the left, as our forebrain, midbrain, and hindbrain are starting to fold and create the flexures, the third aortic arch and the dorsal aorta have already moved ahead up into the primitive brain of the fetus and are creating what's going to be called eventually the internal carotid system, or the anterior circulation. Coming up from the rear is our segmental and also contribution from some of the aortic arches and their arteries that will form our vertebral basilar system. And if we move forward a little bit in time, we see the dorsal aorta having a prominent role in this irrigation of the cerebrum and the intracranial contents. And then posteriorly, you can begin to see some of the segmental branches here that are going to give rise, especially from the seventh segmental artery. And these are going to come up and eventually form our vertebral basilar system. And then if I ever had to have a tattoo put on me, I think I would put one of those. This is beautiful imagery of the early neuroanatomy of the fetus. And we see early to late fetal stage, and you can see the development of the vertebral basilar system. If we look at a more schematic view, you see the left vertebral artery and the color coding there. So our fourth aortic arch, our dorsal aorta, are giving rise to the segment where the seventh intersegmental artery is going to arise. That'll eventually become our left subclavian artery, and then the first branch of that being the vertebral. A bit more details is that the first through the sixth intersegmental arteries are going to form these longitudinal chains, and these chains have various parts. As if you look to the image to the right, we see a precostal, a postcostal, and a post-transverse, and it's that postcostal anastomosis that's the most important in forming our eventual adult vertebral artery. On the right side is very similar, and color coding from the aortic sacs that you see on the left, the intersegmentals, and the eventual formation primarily from the seventh intersegmental artery to give rise to the subclavian, and again the first branch of that being the vertebral artery. Some early fetal anastomoses that you'll see from time to time. We'll start off at the top, and we see the persistent trigeminal artery, and again these connect the external and internal systems, vertebral and external systems, external system being the internal carotid artery. So the persistent trigeminal artery that we see there will connect basilar, and then we'll go through the dorsum celli on occasion, and will anastomose with the basilar either at the junction where the PCA arises, and that's a Saltzman type 1, or where the superior cerebellar arises, and that's a Saltzman class 2. The otic artery, as we see, will come off, join the carotid system with the basilar. If you do see that, there's a lot of debate as to whether this actually exists as an entity. I think I've seen one. I think I've seen one in the lab, so I believe they probably do arise. They're extremely, extremely rare. And probably most people have confused a large labyrinthine artery as a persistent otic artery, because they're going to travel both through the internal acoustic meatus. The hypoglossal artery, so it and the trigeminal are in the 0.2 prevalence of cadaveric specimens. Hypoglossal will travel through the hypoglossal canal and also joins those two vessels. And then I think most interesting for our talk is the proatlantal artery. Type 1 will come from the internal carotid artery and join the basilar, and the type 2s go from the external carotid artery and join the basilar. And interestingly, and I think I believe this now after seeing several studies, the existence of the proatlantal artery, even though we see it in its full elaboration and call it that, I think we see it all the time, and it probably remains as the horizontal or the atlantal segment of the vertebral artery. So you're probably seeing what the proatlantal artery was in adults as well. The image on the right shows you if you put all the persistent fetal vessels, which you'll never see that in an adult, and showed the different foramina that they're leaving through, that's what it looks like. Here are the two types of proatlantal arteries, the type 1 and the type 2. So let's move on, look at some of the segments of the vertebral artery. So the first segment is arising off of almost always the first branch of the subclavian artery, and is termed the extraosseous branch. Then the foraminal branch, V2. The V3 and V4 branch, or V3 terminology, is varied in the literature. Some people will use a part that is through the second transverse foramen. We're going to call everything that's in transverse foramina V2, and then the V3 is after it leaves the transverse foramen of C1 and prior to going intradurally, and we like to use the term pars atlantica for that. And then the intradural segment, V4. So where does the VA vertebral artery first enter into a cervical transverse foramen? That's a nice little simplified depiction. Almost all are going to be at C6, or a vast majority, right at Shoshanak tubercle, the carotid tubercle. And then you can see it descends as you go higher. So C5 at 5%, C3 maybe 1%. You shouldn't see it above that. And then C7 is very uncommon. How about the branches of V1, right? So this first little branch in the so-called vertebral artery triangle, which is made up of the longus colli, the anterior scalene, and the first rib. In that little area, you see muscular branches that go to those adjacent muscles that we just mentioned, so prevertebral and scalene muscles. You see spinal branches that will go back and supply radicular segments. And also you can occasionally, at this point, since it's over the neck of the first rib, you'll see branches to the stellate ganglion. V2 branches, you have many more. So again, those same spinal, muscular, you tend to see more bony branches from the V2 segment. You'll see an artery of the cervical enlargement on occasion. This is comparable to Adam Kjavitz's artery in the thoracolumbar junction region. Two meningeal branches are usually seen in the V2 segment going to the anterior and posterior spinal dura. And then ganglionic branches that do not necessarily go back and supply the spinal cord, but end on the dorsal root ganglia and adjacent rootlets. A very highly schematic image or two that shows you some of those branches. And you see in the V2 segment all the little bony and muscular branches. And for the most part, those can be taken surgically. We shouldn't forget about the branches of V2, especially some V3 that supply the odontoid. This is a huge component of odontoid fractures, and this very delicate little arcade that ascends up from the V2 branches is another component that should be remembered. V3 segments, we see our radicular muscular branches. There's a large one to the dorsal root ganglion of C2 in the greater occipital nerve region and adjacent cord. There's also usually a very large muscular branch, Salmon's artery, that comes off of V3 that will supply usually the semispinalis capitis or the suboccipital muscles. And that branch usually will anastomose with the occipital artery, a descending branch of the occipital artery. I've also listed here ascending pharyngeal can come into that anastomosis, and then lastly the deep cervical branch of the costocervical trunk can contribute to this little muscular arcade that we find over the V3 segment. A posterior meningeal branch, a variant where we can see branches to the AO joint, and then most importantly, and if you take home nothing else, when you're doing extradural dissections in a suboccipital approach. Depending what literature you read, between 5 and 20% are going to have a pica that arises from that V3 segment. And as Dr. Roten has shown here very nicely in the lower image, you see the pica here coming off of the vertebral artery segment. And people will confuse that with Salmon's artery or muscular artery, but if you see something that looks like it's going into the atlanto-occipital joint or junction through the dura, not into muscle, then you should be very weary that that's pica. V4 branches, pica, which we'll get to in more detailed. We also have perforators of V4 that are going to supply the foramen cecum at the pontomedullary junction in the midline, usually anterior spinal, posterior spinal, in about half the population. V3 can also give rise to the posterior spinal in another half, and then very rarely or uncommonly, pica can give rise to the posterior spinal. Lateral spinal artery that not many people talk about, that's traveling just like the posterior and anterior spinals, but in a lateral trajectory, travels with the accessory nerve as it's coming up from the upper 5 or 6 segments of the spinal cord. And the key to localizing the lateral spinal artery in dissection is that it's posterior to the denticulate ligament, just like the accessory nerve is. And then finally, a V4 branch, the posterior meningeal artery. This is a picture from one of our older publications that shows you a great relationship. You should keep in mind as surgeons that the vertebral artery is anterior to that highest denticulate ligament. So it's protected there at the junction between the V3 and V4 segments. And then running behind that highest dentate ligament, we see the rootlets of the accessory nerve and also a lateral spinal artery and posterior spinal artery in this case. So exposure of the vertebral artery from a suboccipital region, going left to right, we've gone down through the semispinalis capitis, the trapezius, splenius capitis, and now you're looking at, on the left, all of the suboccipital muscles. On the right, we're flipping over, reflecting medially the rectus capitis, posterior major and minor, and on the right, the oblique capitis superior and inferior have been removed, and you can now nicely see the V3 segment of the vertebral artery, just here, riding over the posterior arch of C1. And if you put those suboccipital muscles back, that artery lives in the floor of that suboccipital triangle. And if you push your finger in the floor of the suboccipital triangle, you'll feel the posterior arch of C1, you'll feel the posterior atlanto-occipital membrane. And then with dissection, you may see running between the posterior arch of C1 and the V3 segment, the suboccipital nerve, which is the dorsal ramus of C1. This shows nicely all the muscles removed, and we see the V3 segment here wrapping around. There's the dorsal ramus of C1, the suboccipital nerve, which in most people just innervates the suboccipital muscles and semispinalis capitis. Then more medially, we start to see the accessory nerve and its branches covering the backside of the vertebral artery. And then what branches do we see here just anterior to the vertebral artery at its V4 segment? Right there at the pointer. Hypoglossal nerve. So hypoglossal nerve is separated from the accessory nerve at this craniocervical junction by the vertebral artery. This is not a compatible dissection with life, so don't do that in the OR, but this is cerebellum removed, and we see the floor, the fourth ventricle. It just gives you the relationships of the vertebral artery, its intracranial segment, and the lower cranial nerves. So vertebral artery variants come in a plethora of different forms and shapes. You can go from not having a vertebral artery, having a huge vertebral artery. In general, most people, about 50% of us, the left vertebral artery is larger than the right vertebral artery. You can remember that because the right transverse sinus is usually bigger than the left transverse sinus, so it's the opposite. And about 45%, the right can be at least comparable, and then occasionally it can be bigger. You can see from the images on the right that we can have fenestrations galore for the vertebral artery. We can have absence on both sides. That's been reported. So lots and lots. Just you should expect variation. So Sir William Osler said that variability is the law of life, and that is absolutely true when you look at the vertebral artery and its variations. And just to give you a small snapshot, and people actually measure these, and Dr. Iwanaga is here, and he's from Japan, so I can poke at him. These are mostly Japanese studies where they've traced out all these fine little minutia branches of the anterior spinal artery and its variants. And it comes in so many different forms and flavors that you're almost led to believe that we're all put together a little bit differently. One important surgical anatomy comment about the variations are not so much with the artery itself at the V3 segment, but if you look at the arrows there, this is a bony bridge or a posterior ponticle, and it's forming a complete bridge in this case, so that on the left and right sides of these pictures, we see an arcuate foramen. So sometimes with a suboccipital dissection, when you're cauterizing out laterally, waiting to see vertebral, and you don't quite see it, and you keep going and going, it could be, and up to 5% of the population, covered with bone, so that you can step off this little bony bridge and damage the artery, which I've seen before. PICA segments. So PICA, very important. We see its schematic course here. And as you look from the vertebral artery anteriorly, right, this first little green segment, and then we see red, blue, and then our cortical branches in red. We have an anterior medullary segment that begins off, right, and that's going to give perforators to the medulla and upper spinal cord. A lateral medullary segment just behind that, posterior medullary segment in blue, and then we see our supratonsillar segment, and then our cortical segments. And that supratonsillar segment probably has the most variation of any of these branches, with cranial and caudal loops and the different variations that you see. Exposures of these different branches of PICA. The first segment, just a typical cisterna magna exposure. The caudal loop with anything in the cerebellomedullary fissure. The cranial loop, if you go up into the tonsillar uvular fissure, if you're going to do a telovelar approach, then you're going to see PICA branches. And then finally, this fourth segment, tonsillomedullary fissure, is where you're going to see that more or less. So the direct branches off of PICA, I mentioned to you, we have perforators, and perforators are defined by different people differently. And we'll see some that are direct perforators, some that come off an artery. This goes for PICA and many of the other vessels we'll talk about, and then course way around to a distal destination before they perforate the brainstem. We can call those circumflex vessels, and they've been named long and short circumflex vessels. And then the cortical branches of PICA are the vermian, tonsillar, and hemispheric that you're aware of. We can also see a meningeal branch of PICA, and the one that's more commonly seen is the artery of the falx cerebelli that runs between the two halves of the cerebellum. What venous sinus runs with the artery of the falx cerebelli? Anybody? Occipital. So the occipital venous sinus. This is a schematic view that shows two different authors. It depends if you're looking in the French literature, if you're looking in the non-French literature. But we see direct perforators or posterior median perforators on the left. Then we have the short circumflex vessels and long circumflex. Others have termed these as anterior medial, anterior lateral, lateral, posterior. Just the same structures, just different ways and different terminologies. Even Dr. Roten, God bless his soul, in his textbook mixes the two back and forth. So you'll see both of those descriptions throughout the book. The perforators, important, right? And people have told you they're important since you were in a first-year resident. They go to things that are deep and very important, the nuclei of the brainstem. And probably the take-home message of this beautiful cadaveric injection with black India ink on the left, and then the schematic of where those little arterial branches are going. The anterior branches, the anterior perforators, tend to go deeper into the stem. The posterior perforators don't go quite as deep and are more localized, but there's a rich mixing between the two. Again, because this is a big deal, if you take it operatively, the PICA variant that I showed you earlier, where PICA is arising from the V3 segment in an extracranial location. PICA variants that are more common, depending on a low or high relationship to the olive. That's usually the landmark that's used in regards to where the pica is. You can have duplicated pica, you can have absence of pica, you can have vertebral artery that ends as pica. You name it, it can probably happen. Interestingly, if you look at the cortical trajectory of the different branches of pica, we see that, you know, branches that go out, if you look at the lower left image, fully to the posterior edge of the cerebellum on the cortex. That's seen in most people. And then those more lateral or marginal branches, as you march around the circumference of the cerebellar cortex, become a little less. And then, not that you ever have to know these, but those are some additional AICA and PICA variants. They tend to go together, so that if you see a PICA variant, it's very likely you're going to see an AICA variant and vice versa. So PICA, there's the tonsillar branches. I come from a children's hospital background in neurosurgery, so we did tons of posterior fossa explorations, and those two little tonsillar branches of pica that we see there was just a daily occurrence as far as where they are, etc. Interestingly, the nice feature of those picas wrapping around the contour of the tonsils is an old mechanism for diagnosing Chiari malformation. So on myelograms, etc., you could see the vessels dipping down under C1 or down to C2 with Chiari 2s and make the diagnosis based on the vessel's displacement. Nice schematics from Dr. Roten's work that shows you essentially that the caudal and cranial loops, if you look at C there, the cranial loops of pica are variable, so that when you, for example, make an incision into the dura at the cranial-cervical junction, even if you're under C1 or C2, you should always expect that there could be pica there. So don't make the knife incision too deeply, or something bad could happen. We also see the variations in the telavelar region of pica on both sides. As far as a posterior CP angle approach, pica is going to be intimately involved with the 9th, the 10th, and the 11th cranial nerves. It's right here. So here's 9, usually a little space between it and the rootlets of 10, and then we're starting to see some of the cranial rootlets of 11. We also see a little tuft of chori plexus that's hanging down out of what? Where does that tuft of chori plexus come from? Foramen oblusca, right? The lateral aperture of the fourth ventricle foramen oblusca. Basilar artery branches. We all know about the bad perforators that we don't want to do anything to or would cause problems for the patient. But the typical branches are AICA, perforators, and the superior cerebellar artery. This is an unconventional surgical approach to the basilar artery from Dr. Roten's work. And if you're seeing that, kudos to you. Dr. Patel and Monteith, I'm sure that's a daily occurrence. Just, you know, take the clivus and throw it in the can. Basilar artery variants. So we see you can have a basilar artery that has no contribution from the vertebral. That's very rare. It can have unilateral contribution. Basilar artery can be fat, it can be small, it can be fenestrated, it can have rungs that we see, it can be separated along its entirety, as you see there in the bottom right. Interestingly, years ago we did a study where we essentially harvested 100 basilar arteries, and we took micro scissors and opened them up longitudinally, and in a couple of them there's a midline septation that shows you the embryologic formation between the left and right vertebrals. And at some point we need to do an endovascular study where we look for that, because you can only see it under the microscope. Basilar artery variants, probably the most common variant is it in the midline or is it off the midline? And you see everything. They can be serpiginous, they can be very rectified, they can have anything you can think about the basilar artery can do. AICA segments, if we look back at this picture, we see that it's been classified as these anterior pontine. That's the most medial arrow there, so coming off and perforating into the pons. Then we see a lateral pontine at the middle cerebellar peduncle. Then at the flocculonodular area, we see a little branch that comes off AICA. And then finally, the cortical branches of AICA. And if you remember that the cortical branches of AICA are going to primarily supply the cortex of the cerebellum that's on the petrosal surface of the cerebellum, just tucked underneath the tentorium cerebelli. So perforators, I love this slide because you don't see that very often. It actually shows you the various perforators you see of AICA that I've put in rectangular boxes for you. So again, that flocculonodular area with those perforators, the medial and lateral pontine perforators, and then we even see a little hint of the superior cerebellar arteries perforators as it's winding around the corner. Labyrinthine artery almost always comes off of AICA. Lots of books show it coming from Basilar. That's very uncommon, as I think Dr. McDougall and Patel and Monteith would agree, and Dr. Lowe. The subarcuate branch, which is always a question that the surgeons ask during a CP angle approach, and you see a branch coming off AICA and just looks like it's dead ending into the bone near posterior to the internal acoustic meatus. That supplies the bone over the semicircular canals, primarily the anterior semicircular canal. And then, as we said before, the cortical branches to the petrosal surface of the cerebellum. Nice schematic that shows the interaction between the AICA and the 7th, 8th cranial nerves, and in particular between the nervus intermedius part of 7 and 8. And I'll show you a picture that shows those various convolutions that can occur. This is a more surgical approach, and we see on the left there the branch to the subarcuate region. We see the intimacy between AICA and 7 and 8. And if you drill out via, for example, a Kawase approach on the right, we see the sealing of the internal acoustic meatus that's been removed, the inner durus or in the porus acousticus, and we see there in the middle the nervus intermedius. We see a knuckle of AICA protruding up. This would be the meatal segment of AICA, and then we see 7 and 8 split on either side. Also direct recurrent branches that can come off at that point and go back toward the brainstem. This is a study that we published recently that just shows you the multitude of different variations between AICA and 7-8 complex, including nervus intermedius. We should also remember that the labyrinthine artery doesn't just go inside the internal acoustic meatus, and that's all she wrote. Right? It continues on and supplies the cochlea and the semicircular canals, as this schematic image shows. So labyrinthine artery is something that should be maintained at all costs. AICA, again, multiple variations in its origin, its course. It can be duplicated, it can be absent, it can come from regional vessels instead of coming directly from the basilar. Superior cerebellar artery and its segments. We have, as you can see, looking at the front and anterior pontomesencephalic portion, right? So here, we then, as we go back, a posterior or lateral pontomesencephalic, and then we move to our cerebellomesencephalic, and then our tentorial surface, which is where the superior cerebellar artery is going to supply the cortex of the cerebellum. And superior cerebellar is usually the dominant cerebellar artery for the cerebellum. We can see that from this lower image. If you see the color coding there, and superior cerebellar artery in most folks is going to supply the upper half of that hemisphere. Perforators come off, as we just showed you, on the different segments of the superior cerebellar artery, pre-cerebellar and then cortical branches. This nice dissection on the right shows a supracerebellar approach to the pineal region, and we see the skeletonized tentorial venous sinus that's over the top or the surface of the cerebellum, and then all of this is from the superior cerebellar artery. Remember that the superior cerebellar artery is running in the ambient cistern, and if we're looking at a lateral view, a subtemporal approach to the lateral midbrain, you'll see that the fourth cranial nerve and superior cerebellar artery are running low in the ambient cistern. PCA is running up higher, and then what's the highest structure that we see running in the ambient cistern that we don't want to cause bleeding if we do something to it? Vein of Rosenthal. So vein of Rosenthal highest, PCA, superior cerebellar artery, and fourth nerve a little bit lower. This shows you from next door in the lab, the arrows. We've taken off most of the midbrain, so we see the basilar apex just here. Then we see the superior cerebellar artery with its proximal and more distal segments. And then this shows nicely that, you know, the medial segments or medial branches of the superior cerebellar artery are going to go back and supply perforators to the lateral brainstem, and these more lateral branches that are also terminal branches are staying over on the cortex. So superior cerebellar artery variants, again, anything you can think of, duplication, absence, they move up and down as far as their origin, can come from adjacent vessels. The one on the upper right, you can see superior cerebellar artery arising from the PCA. More variants, and the one to focus on is the lower left image there, and we see that most of the cerebellar cortical branches go out to the posterior margin of the cerebellar cortex, and then as you wrap your way around more anteriorly, you have a less chance of having those vessels. All right, we've worked our way to the top of the vertebral basilar system, and we're looking at the posterior cerebral artery. We're seeing it wrapping around the cerebral peduncles and then running posteriorly in the ambient cistern to join the quadrigeminal cistern and then have its cortical branches. You can also see a point where the left and right posterior cerebral arteries come closest to each other. This is referred to as the collicular point. This is a nice subtemporal approach, and we're seeing the lateral edge of the tentorium there. The nerve that's most anterior, this is our oculomotor nerve. We see the fourth nerve here, and both of those nerves generally are traveling through between the PCA and the superior cerebellar artery, just at different points. We see the PCA as it wraps around the midbrain and is coursing posteriorly, is going to give off two prominent branches, a posterior medial choroidal and a posterior lateral choroidal. The posterior medial is more medial, usually comes off a little more anteriorly, so it can come from the P1 segment occasionally. Speaking of, the segments are divided by the PCOM anteriorly, so the P1 there between origin and PCOM, P2 as we wrap around, and P2 can be further subdivided, as I'll show you in the next slide. P3 as we come back to where the parietal occipital branch will come off of, and then as we enter the calcarine sulcus, the P4 branches. As I mentioned, we can also take P2 and divide it into a peduncular and an ambient section, and those are based on surgical approaches, so that the P2A can be approached differently than the P2B. If we look at the image we took from our lab, you can see the P2 segment. This is a anterior kind of terional approach where we see third cranial nerve, the chiasm, and then the P2 segment there just lateral to that junction. This is another inferior view where we've removed most of the skull base, and it nicely shows the oculomotor nerve relationship. Just here we see the PCOM, and then posteriorly this is our P2 segment. So if we look on the right image there, we're seeing the exposed lateral ventricle, and we see the contents of that, and the chorioplexus there, the hippocampus there, and the temporal horn. Those are going to be fed by the posterior, or from the posterior cerebral artery as it moves around. One of the first cortical branches of that PCA is usually defined as the hippocampal branch that enters into that temporal horn. Additionally, into the choroidal fissure, we're going to see the posterior lateral choroidal branch go in and supply, not as its name implies, just chorioplexus, but also the ependema within the ventricle. And then the posterior medial choroidal will extend posteriorly and enter into the, with the velum interpositum, as I'll show you. So let's look at just some of the general branches. So the perforating branches, as we see with almost all of these vertebral basilar structures, and these come from direct and circumflex, both long and short. They come from the PCOM, from P1, P2. We have anterior thalamoperforators from the PCOM, and then posterior thalamoperforators from our P1 segment. We also have thalamogeniculate from the P2 and pedunculars from the P2 that I showed you earlier. You can also have a ventricular, direct ventricular branch from V2, and majority of folks, cortical branches. Cortical branches have a lot of loose terminology that's used to describe them, but temporal branches, which are anterior and posterior in some people's, the term lateral occipital is used by some. I think it's a good terminology, and then from that arising the anterior inferior, the middle inferior, and the posterior inferior temporal arteries. And then finally a medial occipital stem. Again, I think a good term that gives off eventually our calcarine and our parietal occipital. And finally, one that our residents anyway always forgot about was the dural branch that comes off of either the P2, sometimes the P1 segment. When we looked at it, it was P2. This is the artery of Davidoff and Schlechter. And if you see in the picture here, that branch, let's say from the P2 segment, supplies the incisura and anastomose with Bernasconi and Casanari that's arising from the meningohypophyseal trunk of the cavernous part of the ICA. Major PCA branches, so hippocampal, as I mentioned to you, the choroidal branches, the temporal branches with the middle posterior temporal being a variant, the splenial artery, which I'll just alert you, a lot of people in the literature also call that the posterior pericallosal, so you see both of those terms. And then the more well-known cortical, parietal, occipital, calcarine, and if we throw in the PCOM there, then the anterior thalamoperforators. The P1 segment, also called the precommunicating, the mesencephalic or the horizontal segment, has direct perforators. You can read that list. It goes to very important things in the tegmentum and adjacent areas. The short circumflex vessels just go to the geniculate bodies and stop, so they perforate there and before, and then everything posterior to that thalamic area is going to be the long arteries, which are sometimes called the quadrigeminal or the collicular branches. P2 segment, those direct branches are thalamo-geniculate and peduncular that we just mentioned. They supply not only the brain stem, but also the adjacent cranial nerve, so cranial nerve 3 as it's wrapping around. A nice posterior view, so this is looking in the quadrigeminal region and then the posterior of the naked thalamus on the left, and shows you some of the nice perforators from these branches that we just mentioned and where they go and where they can be localized. This is the anterior view that I showed you earlier, and circled there P1 and P2 perforating areas that we find both medial and lateral on the cerebral peduncles. This is a nice image. This shows you the height of the PCA and the ambient cistern and its relationship to the superior cerebellar artery, and also from the circumflex vessels that come from P1 and P2. Here we see the posterior medial choroidal, the quote-unquote collicular branch, which could be a combo of the long and short circumflex vessels. And then we see the medial and lateral trunks of the SCA, which people forget about, but medial trunks going as perforators and then ending in the colliculi and giving off posterior pontine arteries. And then the lateral branch, which can also supply perforators, but preferentially is a cerebellar cortex vessel. P2 continued, as I'm running out of time, but we have lots of branches of P2, the choroidal vessels that I've already mentioned, and you can, as with all of our talks, you can see this talk and all the slides on YouTube by tomorrow. So if we don't get to cover everything, you can see that later. I would emphasize that if you're looking through the velum interpositum, as we see there on the left, and open up the velum interpositum, you're looking inside the third ventricle now, and you're going to see two major vessels. You're going to see the internal cerebral veins that we see there being moved laterally, and then the arteries that run in that corridor, and the roof of the third ventricle essentially represent the medial posterior choroidal arteries that will then move anteriorly in anastomose with vessels that we see in the foramen of Monroe. P3 segment, or the quadrigeminal branch, giving off the parietal occipital. And we've mentioned already the P4 segment with calcarine and that quote-unquote posterior pericallosal. Tons of posterior cerebral artery variants. There's a nice one that we looked at recently. There's a fenestrated P1 segment, which is uncommon. You have to mention in a discussion like this, the artery of Percheron, so a unilateral perforator from the P1s that travels up and supplies bilateral thalami. And then our residents, I know, not you, but our residents always forgot that the Percheron or these P1 perforators also supply the midbrain. So you should expect bilateral thalamic infarction with some bilateral mesencephalic infarction when you injure Percheron. And then that's a specimen from the lab that shows it very nicely. All right, last couple of minutes. Dr. Monteith asked me to talk to you about the very confusing literature and terminology of collars, caves, rings of the ICA. And the jury is still out on some of this. I picked very credible authors, and you can read their literature at the origin. But Van Loveren and his group think that the clinoidal segment of the ICA could be either intracavernous sinus or extracavernous sinus based on their findings. Spetzler says, is on the fence a little bit, but comes out and says that the proximal ring forms the roof of the sinus, which that's true, but doesn't lay strong feet down on whether it's intracavernous, extracavernous. Dr. Roten, who's usually the Bible for me, but he says that it's intracavernous. Kobayashi, who's a disciple of the Roten clan, says that the lateral clinoid space is extracavernous, so he's divvying up whether the carotid cave in the lateral clinoidal segment, and carotid cave being the medial clinoidal segment, he's saying one or the other might be intracavernous, so that's hedging a bit. And then I think the take-home message for you is that the definition of the cavernous sinus is the issue with all of these publications, so that some of them are including little tributaries that are draining down through the roof of the cavernous sinus and including themselves between the collars, outside of the collars, but are tributaries to the cavernous sinus and not actual cavernous sinus. They're being misled and calling it cavernous sinus. So if you keep that in mind, that a tributary doesn't necessarily mean you're in the sinus, and then I think some of this makes a little more sense. Let me get to this last slide. So this is a nice picture from Dr. Spetzler's group that shows the rings. One critical thing is to remember that that distal ring is what you're seeing if you're doing a suprasellar approach. That's the first thing you'll come to, and there's a concavity around the neck of the ICA as it's coming up through the cavernous sinus, and medial to that would be the carotid cave or the medial clinoidal segment. And if you then go through that connection, you may start to see tributaries that are going into the cavernous sinus, especially from like some of the peri-ICA venous tributaries. And then the proximal ring we see is more deeply located. Some differences. The distal ring, if you look in the lab when we do that exposure, is almost continuous with the falciform ligament that bridges over the optic nerve. So that comes back, is continuous with the anterior clinoid, and then comes down and helps contribute to that distal carotid ring. That thing is fused to the carotid. So anyone that tells you they can take off the distal ring and leave the artery intact, I think that's probably incorrect. They're probably getting into the adventitia, and that's been shown with histology studies. The proximal ring is more mobile, so you can move that, you can take it off, and then move the cavernous, if you do that exposure, cavernous ICA around, so it's more mobile. The two together form this union on the lateral side, just behind the anterior clinoid, and then you see on the right image the quote-unquote carotid cave that's here. Also, that carotid cave is where you're going to see the superior hypophyseal artery come off of, more medially, and then the ophthalmic artery usually from the anterior region of that little scooped out segment. This just shows you quickly in my last slide the falciform ligament there over the needle and between the right optic nerve, and again that's continuous with that distal dural ring, and then a dissection from the lab with the arrow showing you the proximal ring, and we've skeletonized all of the cavernous sinus. You can see the ophthalmic artery there coming off just medial to the ICA. And again, this shows you that there is mobility of the proximal ring. And then lastly, it depends a lot on the coiled nature, the tortuosity of the ICA at this point, where the clinoidal segments are, where these ligaments are. All right, that's a smattering of posterior circulation. So we're out of time, but if you want to grab me during the breaks, I'll be glad to answer any questions for you, and thank you for your attention.